Welcome to Briefcase, the series from OUM where we break down real, closed chiropractic malpractice cases so you can learn what went wrong, how cases were defended, and what steps practitioners can take to protect their patients and their practice. Every case carries a lesson. This is one of them. A 36-year-old male presented to the insured chiropractor 3 weeks after a motor vehicle accident. His vehicle had been struck from the rear. He reported burning pain in his hands and aching pain in his lower and upper back. The insured provided gentle adjustment and scheduled the patient to return 2 weeks later for x-rays and a more thorough examination. At the follow-up visit, the patient complained of moderate low back pain, heaviness and tingling in his legs, moderate neck pain, numbness and tingling in his right hand, and headaches. He also reported a history of prior chiropractic treatment following a motor vehicle accident the year before. On examination, the insured noted bilateral clonus of both feet on dorsiflexion. Reflex tests were within normal limits. Palpation produced tenderness across multiple cervical and thoracic regions. X-rays revealed L5 disc degeneration, degenerative disc disease at C5-C6, and malposition at C1-C2. The insured diagnosed acute cervical acceleration and deceleration injury, lumbosacral sprain and strain, and discal tearing of the lower cervical and lumbar spine. He initiated a course of chiropractic treatment using the directional non-force technique and scheduled daily visits for 2 weeks, noting that an MRI might be necessary if the patient did not improve. Over the following days, the patient's symptoms continued to evolve. He reported less heaviness in his legs, then strange paresthesia along his right flank, then a sensation that cold water felt hot. His neck pain decreased, and he reported walking better. But then his left leg buckled. The following day, he presented with a left foot drop. The insured ordered an MRI of the lumbar spine to investigate the foot drop and continued chiropractic treatment while awaiting results. The MRI showed protrusion at L3-4 and L4-5 with potential nerve root impingement, along with non-compressive central disc herniation and congenital spinal canal stenosis. The insured did not believe the lumbar findings explained the foot drop, so he ordered an MRI of the brain. That MRI revealed an abnormal signal in the paranasal sinuses and right middle ear. The insured then referred the patient to an orthopedist. The patient never returned. Instead, he saw a different chiropractor the following week, who ordered x-rays and performed several spinal adjustments and electrical stimulation on 2 occasions. 4 days after that final visit, the patient saw an orthopedic surgeon who referred him for a stat thoracic MRI. 2 days later, a cervical MRI revealed a large disc herniation with cord impingement at C5-C6, impingement of the right C6 nerve root, and cord edema. The patient underwent emergency neurosurgery for cord compression at C5-6 the following day. He recovered from surgery, but was left with permanent spinal cord injuries and neurological deficits. He has difficulty with ambulation even with an ankle brace and cane, experiences daily severe pain in his right upper extremity, right hip and thigh, and is no longer able to work. The patient hired an attorney and filed suit against the insured and the driver who caused the accident. He did not allege the insured caused the underlying herniation. Instead, allegations focused on the insured's failure to appreciate the severity of his injuries. Specifically, the claims included failure to appropriately examine the patient prior to the initial adjustment, failure to recognize neurological symptoms consistent with cervical myeloradiculopathy, failure to timely refer the patient for consultation with an orthopedist or neurosurgeon, and the assertion that delayed referral allowed a treatable condition to become a permanent injury. The defense enlisted expert reviews from a chiropractor, 3 neurosurgeons, and a chiropractic neurologist. The panel's consensus was that the patient's initial presentation with bilateral clonus, combined with clinical findings across all 4 extremities, warranted an immediate referral for a cervical MRI and further workup. The experts also determined that continued chiropractic treatment worsened the outcome and contributed to the permanency of the neurological deficits. Without expert support for the defense and facing the potential for a verdict exceeding policy limits, the insured agreed to settle prior to trial. This case is a stark reminder of how quickly a clinical picture can change and how much depends on recognizing the warning signs early. The presence of bilateral clonus at the very first examination was a red flag that pointed toward a serious spinal cord issue. Tunnel vision on the musculoskeletal complaint, without accounting for the full neurological picture, left the patient without the referral he needed. These are the moments where thorough documentation, differential thinking, and a low threshold for referral can change everything. Take a thorough history and perform a complete physical examination before initiating any treatment. Document both positive and negative findings and address what you observe. Consider and document differential diagnoses based on the full scope of the patient's presentation. If there is any possibility of a serious underlying condition, refer promptly for further testing and workup. And if a patient is not improving as expected, reevaluate, modify the plan, or refer. Do not wait. Protecting your patients starts with the decisions you make in the room. To learn more, safeguard your practice, reduce your risk, and download this case, visit us at OUMChiropractor.com.